We remain in the same area of difficulties, but come really for a more direct, practical approach covered by Mark Sulkowski from Baltimore, United States. And this is the retreatment option in patients who have failed the DAA regimen. Mark.
Great. Well, thank you very much. It is a true pleasure to be here, and I actually really enjoyed the last discussion. It does play very well into what I'm going to talk about in terms of themes of what to do with patients who fail these highly effective oral regimens. So moving ahead, these are my disclosures. In this era, in many settings, we have access to highly effective oral regimens combining multiple DAA classes. This slide depicts some of those that are approved by regulatory authorities worldwide and some that are still in development. These all lead in clinical trials to SVR, or cure rates greater than 95%. But I would point out that if you cure 95%, that would mean that 5% of patients fail to achieve SVR and are hence treatment failures. Another thing to point out on this slide is that you'll see that many of these regimens have a backbone, if you will, or reliance on inhibitors of NS5A, which in general are first-generation inhibitors and often have cross-resistance profiles. So as we go forward and think about what to do next, an important consideration is going to be what's depicted here in this slide. How were they treated the first time? What regimens did they receive? What classes of antivirals did they receive? And we'll touch on that in much more detail. So the good news is failure is uncommon, but there are still patients that need antiviral therapy in our practices. I'll start with a patient that's in my clinical practice, a 63-year-old man with compensated cirrhosis. His Child-Pugh score is A, his MELD is 12, he's got 1A, he's IL-28B TT, and black race. In 2002, he had a null response to peg interferon and ribavirin. In fact, his viral load at week 12 was higher than his baseline viral load. In 2013, he enrolled in clinical trial. He was assigned to a treatment with ledipasvir sulfosphate for 12 weeks. He responded beautifully, followed by relapse. After this, he was then treated with cemipivir sulfosphate ribavirin for 24 weeks. Again, responded beautifully on treatment and had a post-treatment relapse. So I want to talk just a bit in broad terms about causes of HCV failure. We can think about these as patient-related factors. Cirrhosis clearly impacts the ability to eradicate hepatitis C. As was discussed in the last session, the immune system, and IL-28B TT is perhaps a marker of a poor immune system, also plays a role. Higher viremia levels at baseline. 1A may also be an issue, the presence of drug resistance we just focused on. And then, of course, there's the patient factors of adherence to therapy. We don't know how many doses can be missed. And interrupted treatment, a patient who misses between week 4 and week 5. And then, of course, there are drug regimen-related factors, things like side effects, perhaps suboptimal pharmacokinetics. Maybe a patient who has a problem with penetration in a cirrhotic liver, perhaps it's absorption due to pH issues in the stomach. And then there's the issues of using drugs with suboptimal antiviral potency against some regimens. So it's important to consider these factors. So back to my patient. He was 100% adherent. Indeed, his level of obsession about curing his hepatitis C led him to take his medications at the exact same time every day for the entire treatment course. And after his second failure, he underwent HCV resistance testing available commercially in the United States. NS5B was wild type. NS34A had both the Q80K as well as a position 155 mutation. He also had NS5A variants detected. He remained highly motivated to be cured, and he is currently receiving sofosbuvir, umbidisvir, paritaprevir, ritonavir, dusabuvir, and ribavirin. Now, the question I want to touch on here, is this rational? Is that approach really an important one? Now, I can't tell you whether it's responded. He literally just started this regimen 4 weeks ago. But I want to go over some themes of how to approach HCV failure. The first point, which I won't touch on any further, is ask the question, is this truly recurrent viremia, or could this be reinfection? It's very important to note that reinfection can occur, and for these so-called late relapses may actually be the most common cause of recurrent viremia. The second question is, did the patient actually take their drugs? Do we think they did based on their pharmacy fills and their importance? The next, I agree with the comments of our last speaker, that we should perform resistance testing of the drugs used, and we should assess the available classes, including NS5A, NS3, and NS5B. And then this important question, what is the medical need for retreatment? This is the question came up as well. Does the patient have significant liver disease or extrahepatic manifestations that require a cure today as opposed to 2 years from now? So some 3 basic principles that I'll discuss in further is that the next regimen should include at least 2 antivirals predicted to be active based on their drug treatment history, what they received, resistance testing, and the mechanism of action. It's not just the lab profile that says a resistant variant is present or absent. It's actually their treatment history as well. The second is they should receive ribavirin, and I'll talk about that. And the third is they should receive longer therapy. I say if 12, then 24, although we'll look at some data for 16 weeks. So let's first focus on this idea of using new drugs or drugs that remain active based on their treatment history, resistance testing, and the proposed mechanisms of action. Well, this is some early data, the combination of decladisvir and sofosbuvir for patients who had failed telaprevir and bocephevir. And this looks at the viral kinetics over the first 14 days. And the 2 lines show patients with NS3 polymorphisms and those without. And what this demonstrates, as one might expect, using sofosbuvir and an NS5A inhibitor, no impact on antiviral response over the first 14 days when using 2 new drugs. And indeed, in the ION-2 study published by Dr. Nid Aftal, the SVR hepatitis C cure rates were not impacted by the presence of prior telaprevir or bocephevir failure when using a NUC plus an NS5A inhibitor. So proof of principle that 2 new drugs should be effective. Now, I would point out that it's not simply switching to drugs of a new class. We do anticipate that in the foreseeable future, the next several years, we will have new drugs in the same class that have activity against variants selected by first-generation therapies. So, for example, grizopavir, in a study published in Clinical Infectious Diseases, you can see that grizopavir, a protease inhibitor that you'll hear more about in Dr. Feld's presentation, remains active against the position 80 and 155 variants. And indeed, there was a study conducted where patients were retreated following failure of telaprevir, bocephevir, or samipravir, called the C-salvage study, where patients got an NS5A plus a PI. So in theory, 1 new class, NS5A, and a use of a protease inhibitor that looks active. And indeed, the data suggest this approach was effective, even though they were retreated with a protease inhibitor. So look for new drugs as potential activity against these first-generation failures. Now, what we might see in the not-too-distant future is the use of regimens that include multiple DAAs. So in this case, a sofosbuvir, NS5B, 5816, a NS5A, and a protease known as 9857. Now, I highlight 30 patients treated by Professor Ed Gain in New Zealand, and they had failed multiple different DAA regimens. You can see them in the lower corner. And in this case, most of the patients were getting at least 2 new drugs. They were getting a NUC, an NS5A, or a PI, and although the regimens were highly variable, in many cases they were actually getting new drugs. You can see the characteristics presented there, but the reality of it is, when treated for only 6 weeks, the cure rate was quite low. In 20 out of 30 received cure, and there were 10 relapses. So a couple of points here. New drugs active against the virus are important. They're necessary, but may not be sufficient. So if you take my 3 principles of adding ribavirin, using new drugs, and going longer, what was not done here was an extended duration of therapy. And in my mind, patients who fail the first wave of oral therapies need to be treated longer the second time. This is a very important proof of concept study that shows 6 weeks with new drugs in 20 out of 30, but certainly not a high enough cure rate going forward. So duration of therapy is important. Now, what's interesting about these very short courses, and depicted here, These were the retreatment of patients in Synergy. In Synergy study, they used lead soft, so NS5A nuke, plus a PI with or without a non-nuke. And they received only 4 weeks of treatment. They retreated some of these failure patients with ledipasvir, sofosbuvir for 12 weeks. Now, in theory, they're not adding enough new drugs, and this should not potentially have worked. But what they saw was very high response rates. And what this implies is that patients who received a short course of therapy may respond to a longer course of therapy the second time around. So we don't know yet whether these ultra-short courses of therapy will have the same impact on retreatment that the longer courses do. But here, the duration of treatment went from 4 weeks to 12 weeks, and in some patients from 6 to 12 weeks. So I'm going to move to talk about ribavirin. Ribavirin remains a topic of discussion in the era of hepatitis C DAAs. Why does it remain a topic of discussion? And I would argue because it has a unique role in preventing the emergence of resistant variants. I would point to the PROVE-2 study. Now, we don't like to talk about peg interferon and telaprevir in this modern era, but in this very important study, patients were randomized to telaprevir peg plus telaprevir peg and ribavirin for 12 weeks. During that 12-week period, the HCV breakthrough rate in the ribavirin-free regimen was 24%. If you added ribavirin, it was as low as 1%. And indeed, the strongest performing drug in the PROVE-2 study was not telaprevir, it was ribavirin, leading to a 36% higher cure rate. I also point you to a very early study that Professor Zoizum presented with oral therapies of a non-nuke that is now on the trash heap plus a protease. The upper figures are no ribavirin. And you can see that during these initial study days, the viral curves show a lot of variants with resistance breaking through. If you add ribavirin, you see a smoothing out of the response. Now, this was a regimen that was destined never to be very effective, but ribavirin helped. When we look at the so-called 3D regimen in 1B patients, we've talked a bit about the resistance profile in that group, ribavirin is not necessary. They don't break through with a PI, NS5A, and a non-nuke. But what about L1A patients? If we look very closely at the study by Peter Ferenczi and look at how the patients who did not get ribavirin failed, 1A patients, no ribavirin, 16 virologic failures. If you add ribavirin, the overall cure rate goes to 97%, but virologic failures drops from 16 to 2. I would argue that the main role of ribavirin in 1A patients is to prevent the emergence of resistant variants and is really playing a role here with the 3D regimen. And finally, some data that was presented by Christoph at the most recent EASL meeting, looking at these 513 cirrhotic patients, 511 of them who had resistance-associated variants. And what I want to focus on here is the patients with resistance-associated variants, or RAVs, by duration and the administration of ribavirin. So if you look at the 12-week durations, no ribavirin, we're in the high 80%, 88%. With ribavirin, it goes to 94%. Now, is that statistically significant in this post hoc subgroup analysis? I can't comment on that, but it's a trend that we also see in the patients treated for 24 weeks, going from 85 to 100%, suggesting the reason the Sirius study shows you can use 12 weeks plus ribavirin in cirrhotics is because of the ability of ribavirin to handle NS5A resistant variants. So in my mind, ribavirin is an important drug to add in patients who fail. Now, what about longer therapy? We've known, as was alluded to earlier, one of the very first studies of interferon gave 18 months of interferon alpha alone, published in New England Journal of Medicine many decades ago. And when you did that, gave 18 months, you saw lower relapse rates. So longer therapy, perhaps by allowing the liver to eradicate the remaining virions, does seem to be important. So if we look at this issue of duration of therapy, you've already seen a version of this slide from Christoph's presentation. If we look first at treatment-naive patients treated for 8 weeks, 12 weeks, or 24 weeks, in the green color, you see the presence of NS5A resistance-associated variants thought to confer a 100-fold decreased activity of the NS5A inhibitor. And we see with shorter therapy some impact. As you go longer, particularly along the bottom in the treatment experienced patients, you're seeming to overcome the presence of resistant variants. So longer therapy perhaps is quite important in a patient with poor immune function defined in a rather vague fashion. Now, this is also demonstrated by the grazoprevir-elzevir plus ribavirin study with treatment-experienced patients. Now, these were patients who failed PEG-ribavirin, and they were randomized to receive 12 weeks or 16 weeks with or without ribavirin. Now, it's important, as I've highlighted in the figure below, to look at the rebound, that is viral breakthrough rate and viral relapse rate. And what the study demonstrates, albeit a relatively small cohort of patients who got 16 weeks plus ribavirin, no cases of viral rebound or viral relapse, that is true virologic failure, when one gave 4 more weeks of therapy and when one added ribavirin. In contrast, if you added ribavirin but did not extend, you still see 6 failures in that group. If you extend but don't add ribavirin, you still see more failures, 6 failures. So it's this combination of adding ribavirin and extending therapy that appears to be important. I assume by helping to overcome baseline NS5A resistance-associated variants that confer a decreased activity to the NS5A inhibitor in this regimen. Now, longer therapy alone is not sufficient. This slide, as you've already seen a variation of this, was the retreatment experiment conducted by Eric Lawis and colleagues in San Antonio, Texas. What they did is took ledipasvir, sofosbuvir failures and retreated them with what one would expect to be only one active agent, that is sofosbuvir. The study was not using baseline resistance testing a priori. They did it afterwards. So patients came in, they had failed ledipasvir, sofosbuvir, they were retreated with essentially the same regimen. And what you can see is in the patients that did not have the presence of resistance-associated variants, 11 patients, the regimen worked quite well. Longer therapy was sufficient. But if you had variants, particularly at position 93 in the NS5A domain, you saw very low response rates. I think what's even more intriguing about this study was when one looks at the 12 patients who failed retreatment, there's the real sense that some of these patients got sofosbuvir monotherapy given for 24 weeks. Now, one of the great features of sofosbuvir in retreatment is it's been demonstrated that you can reuse sofosbuvir and achieve antiviral activity. But in this case, sofosbuvir alone, a functional monotherapy, if you will, 4 patients had the S282T variant emerge, suggesting that monotherapy with sofosbuvir, although it has a high barrier, is something to be strictly avoided. So how do the guidelines from the various panels put this together? Well, the IDSA AASLD guidelines essentially adopt these themes. They say if you're going to retreat a protease inhibitor failure, a patient who did not receive an NS5A, it's relatively straightforward. Take an NS5A plus a nuke, and you've got an active regimen. That's been proven in randomized controlled trials. The real nuance here is what to do if they failed NS5A inhibitors. And the guidance in the US says that if you have minimal need for cure today, you should wait. We will be smarter and have more drugs in 2 or 3 years. If there is an urgent need, the recommendation is to send testing at a commercially available lab or an academic lab and get the resistance profile back for your patient. You should then select the next regimen on the basis of that resistance profile, and the consensus is that sofosbuvir should be included in the next regimen. All patients are recommended for 24 weeks, and all patients are recommended to add ribavirin. So you can see the table summarizes a bit how you would approach this, but I would point out the final row of this table. If you have an NS3 protease RAV and NS5A RAV, the recommendation is to refer to a clinical trial. So if we go back to my patient, the guidance panel said, we don't know what to do, you should test this patient in a clinical trial. Sounds like very good advice, except there are no clinical trials available for this patient in our region. So the guidance panel has not helped me very much in how to approach this patient. Now, let's take a look at how the EASL panel has addressed this issue. And there are many similarities. They state up front, as does the US panel, that there are no data to firmly support retreatment recommendations. They use a lot of indirect evidence, the kind I've gone through. They talk about using resistance testing, although they certainly say that this has not been proven to be valuable in practice. They talk about using new drugs, and they talk about extending therapy and adding ribavirin, these same three principles that I addressed earlier. In this table, I've highlighted the genotype 1 depicts how one might approach this. Now, they recommend retreatment of those who failed a protease inhibitor using failed an NS5A inhibitor plus SOF with samipivir. Now, there's less Q80K in Europe. In the US, we recommend testing before treating with samipivir because we do have a 40 to 50% prevalence of Q80K. That explains the difference why we don't recommend it for all. Now, for the 3D failures, it's interesting. We know these patients fail with both PIs and NS5A resistance and also non-nuke, and there is a recommendation for retreatment given, whereas the US panel in that case said refer to a trial. We don't quite know what to do. An interesting point for debate. So to summarize the approach to patients with failure, I think the first and foremost is to achieve a cure the first time. There's a lot of discussion about shortening therapy, about how we can get away with this or that, but I think the real goal is to cure treatment with the very first highly effective oral regimen you use, because a dead virus can't mutate and can't cause liver disease. The second point is to assess the reasons for virologic failure. Was the patient adherent? If they missed 40% of their doses, retreating them with a new regimen is not the issue. Addressing the factors that made them not adherent is the focus, not the regimen. I do think there is a role for testing for resistance-associated variants and assessing the medical need. If the medical need is not urgent, defer treatment pending new drugs and new data. If there is an urgent need, select the treatment on the basis of resistance testing, use at least 2 active drugs, one of which is presumed to be the nucleotide analog NS5B inhibitor sofosbuvir. Add ribavirin and treat for extended duration. Now, we've always gone to 24 weeks. I think the Sea-Edge study is fascinating in that it did a 4-week addition, which from a cost perspective, if proven to be useful in retreatment, would be a nice duration of therapy. So with that, thank you for your attention.
Thank you, Mark, for this very thoughtful analysis of the situation. I agree with you. I agree with ASLD guidelines, and I agree with EASL guidelines, but I am missing an indication when interferon is still a good option in taking care of those who are not responding. I was a little bit surprised that you didn't put your patient, actually, he's a well-conserved, compensated cirrhotic patient, on an interferon-based therapy in combination with all the other drugs, really to eradicate the virus.
So we gave him what we call in the United States the kitchen sink, which means everything we had, but we did not select interferon. And I think you raised an important point. The reason we didn't use interferon is he is a Black American IL-20B TT, okay. And we did the experiment twice. I actually gave him PEG-2B, and back in the days it was popular then to switch to the other PEG. Both cases, he did not have a 1 log decline. He was a true flat responder. So he's proven that interferon was an ineffective antiviral. But you do raise, I think, a very interesting point, which is whether or not interferon, which we've abandoned, would be a regimen to add in a retreatment approach to a compensated patient. Now, interferon in cirrhotics has always been poorly effective. So if one looks at the IDEAL study, the SVR rate for cirrhotics was only 25%. So unfortunately, the patients who fail today, the ones that really need treatment, have both cirrhosis and a dysfunctional immune system. So I fear interferon may not help much. But it's an interesting point. Should we take interferon off the shelf and reuse it? I can't argue with that.
So the boson study with GENO3 actually was promoting it, that if you have a potent DAA in conjunction with interferon, it really leads to excellent results. So I don't think we should completely dismiss this opportunity.
No, I agree. I agree. I think it's an important comment.
Mark, with much respect to Stefan and his European colleagues, there's something in those EASL recommendations that makes no sense to me, which is the idea of retreating a non-cirrhotic who failed ladipizvir, sofosbuvir, or decladizvir, sofosbuvir with 12 weeks, the same duration of Simsof. You're taking another class that has a similar degree of potency, combining it with the same sofosbuvir, and you're banking everything on the ribavirin, which I don't think is evidence-based. Don't you think you have to really prolong the duration if you're giving a thematically similar regimen?
So I can tell you that one of the principles that was adopted in the retreat recommendations from the US panel was that we don't want to fail a second time. We gave this person a regimen that in phase 3 clinical trials had a 95% chance or higher of working, and it did not. So if the patient was adherent, in my mind, by definition, there's something wrong with that patient or that patient's virus infection. Perhaps, as Christoph was discussing, their immune system was insufficient. Perhaps it's resistant variants. So the guidance panel took the idea of what can we do? What is in our available armamentarium? We left interferon out, I'll grant that. And one was longer therapy. And in my mind, the data is quite convincing that longer therapy helps. The second was ribavirin. I'm a firm believer in ribavirin for retreatment. And the third was selecting new drugs on the basis of resistance testing. Not a popular concept in the area of hepatitis C, but I think one that will come. So I tend to agree, but I would also say that both the Americans and the Europeans made the recommendations on the basis of zero direct data. We essentially called expert opinion.